Hi, this is Dr. Ashley Brissett, and this is a video showing a standard cataract surgery without any edits. So first I do a paracentesis. I like to make my paracentesis about 45 degrees away from my main incision. I find that ergonomically that works best for me. I'm a left-handed surgeon as well. The next step is to add some preservative-free intracameral lidocaine. And I think that this helps with the patient discomfort during the procedure, and then I also apply some to the surface of the eye. I then add my viscoelastic. This is Viscoat. I go across the anterior chamber injecting and then backfill. And you want to be cautious here when you're backfilling not to overfill the anterior chamber with viscoelastic, because that will then distort your corneal architecture, which can make your main wound less precise, because it puts those stromal fibers on stretch if you overfill the AC. So you don't want to be seeing big globs of viscoelastic coming out of your paracentesis. So you want to fill so that it's an appropriate firmness, but you don't want to overfill. And then I do a biplanar main corneal incision. And then I'm using my cystotome here to start to create my capsular rhexis. I find a capsular rhexis size of 5 millimeters is exactly where I aim for each of my standard cataract cases. I like to use the cystotome there to start to run the capsular rhexis, and then I go in with my capsule forceps and complete the rhexis 360 degrees around. When I'm creating my rhexis, I do like to fold back the leading edge to somewhat create a standing up sail so that it's easier to grab the new edge as you're coming around. The next step is the Hydra Dissection. I do like to remove some of the viscoelastic from the anterior chamber, and then I create a fluid wave and I tap back on the lens, and then I go across to the other side, another fluid wave, and tap back. And then I do micro pulses and micro dosing of BSS about 360 degrees around to better facilitate removal of the cortical material. Then next is the nuclear disassembly. I like to clean up some of this cortex just to improve my view. Then I do a modified stop and chop, which is how I teach my residents. So I'd like to demonstrate this to them before they take over with their own cases, where I do my central groove. And the groove is really important to have the correct depth. You don't need to go as long, but the depth needs to be correct. And then you use your second instrument here. I'm using a Nagahara to create my central crack, and then rotate. I sculpt again, and then I crack. Then I kick over into chop mode, which gives me good vacuum so that I can pull up my first piece, and then I kick it over into quadrant removal to phacoemulsify. Then I pull up my next piece. And you can see here that you want to keep your phaco probe central in the eye, phacoing at about the iris plane, not moving too much, not reaching after pieces. The pieces will come to you, the fluidics do help with that, and you want to be very efficient with your movements. My last I bring up is a heminucleus, and then I chop it. Then I reposition my last piece, bring this up as well. And you want to be very cautious with the last piece to have your chopper or your second instrument back. And I actually lay it on its side so that it's protecting the bag. I'd like to use the pupil blocker here as we switch out the phaco probe for the IA tip, just to decrease any extraneous light on the macula. Then when I'm ready, I come back in with my IA probe and remove the cortical material. And you can see here how easily the cortex comes, and that's because at my step of Hydra Dissection, I help to loosen it at that time. So each step does make your remaining steps easier. I like to get good purchase and then pull tangentially, turning my probe superior and then removing the material in the center portion of the eye. And then we're going to fill the bag with a viscoelastic here. And again, using the pupil blockers, we prepare the lens. And in this surgery, I'm using the preloaded lens from Alcon. I like to use a second instrument in depositing this lens. In this example, I'm using a Sinskey hook. I find it helps with traction on the eye, and then also helps to guide the lens into the eye as well. So this preloaded lens injector abuts the edge of your main wound, and then very simply allows you to inject the lens into the eye. And then I use my Sinskey hook here as my second instrument just to help position the lens. And once your lens is inside the eye, then you can remove the viscoelastic and hydrate your wounds.